Hello, everyone, and welcome to another very special episode of Fiscal Fridays. Today, we are joined by Marc Joffe, a federalism and state policy analyst at the Cato Institute. Marc is certainly a numbers person with an impressive resume. He previously worked for reputable fiscal policy firms like Moody's and the Reason Foundation. Much of his work focuses on government finance and state policy issues. He is here in Idaho because the legislature convened a task force to investigate the budget impacts of switching from a blended financing system to a managed care system run mostly by insurance companies. His testimony was impactful and brought to light some of the experiences states, including Idaho, have had under a managed care system. Thank you, Marc, for joining us today.
Thanks for having me.
Yeah. So how did you get into Medicaid issues as a policy subject in your research?
So I found that there's been a lot of attention on the free market side to education, which is usually the first or second largest budget item in the state, but much less to Medicaid. I think that in the free market community of policy analysts, there's not a lot of understanding of Medicaid. And I thought that it was sort of a hole that I could help fill. And then I came across you, and you're doing quite a great job of filling that hole here in Idaho. But maybe there's some things I've been able to say that supplements your research.
Absolutely. Thank you. And so why is managed care something to be concerned about in Idaho versus our current system where we have a kind of a blend of some managed care and fee-for-service and the value-based system that we have?
Well, I think I want to just maybe help the viewers with my own intellectual journey on this, because I think my view of managed care before I studied it in the Medicaid context is probably typical of what most people think. So managed care, the idea is you don't just get to go to the doctor all the time and not have to pay anything. You have to work with a company or even a nonprofit organization, to make sure that you're not getting unnecessary health care. Because theoretically, like if I'm a hypochondriac, I could go to the emergency room every day, and if I didn't have to pay, well, that's going to become somebody else's responsibility. So, theoretically, the concept of managed care is really good. I remember a very long time ago visiting Kaiser Permanente and seeing how they're really trying to not necessarily discourage people, but not get people so excited about seeking more and more care, but getting them to think about, well, do you really need this procedure or not? So the idea strikes me as being attractive, but when you put it into a Medicaid context, there's one big problem. One of the big levers that managed care organizations have are co-payments and deductibles. So making the patient financially responsible for some of the cost of the healthcare. But with Medicaid, the CMS, the Center for Medicaid and Medicare Services, does not allow that to happen. So there can't be co-payments or deductibles for Medicaid patients. So one of the key ways that a managed care organization has of disincenting the use of healthcare is closed off. And so they really without that, they really don't have a lot of ability to provide a high quality of care at a lower cost. So what they might do is, for example, put administrative burdens or reduce the provider network. But those aren't necessarily things that are going to necessarily result in great patient outcomes. And at the same time, they have to pay their administrative overhead and their profit. So one of the things I testified about today is I looked into the financial statements from Molina Healthcare, which is already a managed care provider here in Idaho and probably would be a bidder if managed care was extended out to the adult population. And their profits for 2022 were over $1 billion. They then had a selling general administrative costs that added up to about 7% of their revenue, which was about $31 billion all told. So ultimately, 12% leaked out from the money that they received from the various states and the federal government that they work with versus what they actually paid out to medical providers. And they're actually not bad because the floor that the federal government has set under the Affordable Care Act is 15%. So an MCO, a managed care organization, has to spend at least 85%, 1 minus 15%, of the money that they take in on medical services. So Molina actually, they're at 12, so they're well within the guidelines, but still that's 12% that's leaking out. and it's not really clear that they can make up that 12% in terms of the quality and quantity of care provided.
Wow. And is it really saving money for Idaho taxpayers in that context? Because under Molina, I know in Idaho we have managed care for the duly eligible population, dental services, behavioral health services, and so is that really saving any money budgetarily?
Well, it's hard to say because you never have the parallel universe where managed care wasn't implemented. Mm-hmm. But we pulled down some figures that are published by Idaho's Department of Health and Welfare, DHW. And I was really shocked by what I learned about the dual eligible population. So they started experimenting with managed care for dual eligibles back in 2014, but the real rollout was after 2018 when they added 2 providers and rolled it out to more counties. After 2017 and through to 2021, you had more than a doubling of the cost per beneficiary within that dual eligible pool. And so I guess we should just pull back and say dual eligibles are folks that are eligible for both Medicaid and Medicare. Mm-hmm. So they are, probably more a sicker than average population, probably a lot of older people in that population who definitely need a lot of care. But you would think that while their overall cost would be higher, they shouldn't be escalating away from the rest of the population, and that's what we found. We found that while this dual eligible population became more than double as expensive to cover on a per person basis, the other eligibility categories didn't change that much. So either there was some problem that's outside of our understanding that managed care didn't fix, or actually managed care caused this problem of increased spending for this group.
And that kind of sounds similar to some of the findings that we found for our presentation as well. So at IFF, we looked at the national costs and tried to compare from a state-to-state perspective per capita in the population. And the reason why we did that was because we wanted to also get perspective on how expansion is also impacting these costs. And what we found was that managed care really made no difference in whether or not states spent more or less money. And then looking at a couple of examples like Sellers-Dorsey, put up Nebraska and Utah as these examples, shining examples that Idaho should emulate in their managed care system if they were to implement it. And what we found is not only did their nominal total budget increase exceed that for Idaho, which is currently under the fee-for-service system, but we also saw that on that per-person cost, both states were much higher than Idaho. Yep. Particularly Nebraska, their cost per person were 16% higher than what we were seeing in Idaho. And it didn't really seem like any of the states had anything to show for it, right. When it was all said and done. And that was another thing. So how does expansion and bringing in the adult population, the able-bodied working age adults, mostly on Medicaid because of income reasons, how does that impact the whole managed care scheme?
Sure. Well, when we looked at the cost escalation in Idaho, it's clearly attributable to Medicaid expansion and then the maintenance of effort requirement that was put in as a result of the pandemic. So starting in early 2020, states were no longer allowed by the federal government to start redetermining eligibility. And so the Medicaid rolls just kept increasing and increasing with nobody being taken off. And as your viewers probably know, that Idaho has now started the redetermination process and the rolls are starting to shrink. But if you look from 2020 until early 2023, there's been this giant escalation because you've had these two events of the expansion and the failure to remove ineligible beneficiaries. So that's really the problem. Now, as far as how managed care would play into this, healthy adults, or I should say, adults below 64, many or most of whom are healthy, are not going to be your biggest cost in terms of Medicaid beneficiaries. It's going to be the folks that are in nursing homes that are really the ones that are driving up the cost of the program, or developmentally disabled people who need daily attention. People who are sort of an average or above average health are not using medical care that much. So there's not really that much managed care can do to reduce their costs. And if anything, it's going to go the other way because they've got to cover that 12 to 15% nut that we talked about before.
Wow, and I think that's probably a really great way to break it down as well, because what people forget about is just that usage piece, and all we see is that per person cost, and we forget about the fact that some of these people aren't using it. And so if you're paying on a fee-for-service basis, then you're not paying for people who aren't using it. But if you're paying on a per-person basis, then as the roles accumulate people, then the program is going to cost more and more. Now it's all actuarially adjusted based on use and things like that. But what we're seeing nationally is it's still not really saving anything. So what is your recommendation for Idaho to do instead of a managed care system?
Well, some of the witnesses today talked about the value care organizations, and that's something that I'm not really that familiar with. It seems pretty unique to Idaho, but as it was explained today, providers do have some quote unquote skin in the game where they're going to share in the excess costs or the burden of the excess costs if those in fact happen. So that really has not been tested. It was first put in during the pandemic. We're sort of getting back to normal. And so it seems like, why don't we spend a year or two seeing how that works out before we, before Idaho tries something, new and definitely not proven.
So in preparation for your testimony, what were some of the examples that you're seeing in other states? So like for our presentation, we looked at Nebraska and Utah specifically in their costs. Did you find anything interesting in other states that you were looking at?
I looked at Connecticut, but just to dwell on Utah for a second, the main witness at the hearing today was Dan Lillenquist, who was a state legislator in Utah who was involved with the implementation of Medicaid managed care there. And I think he set forth some good parameters as to what they could do to reduce the risk that managed care would increase costs. But one thing that he didn't have an answer on, and in all due respect to him, he's no longer in the legislature and he's not really following these numbers. But Utah's expenses, as you've found from your own research, are significantly higher than Idaho's. So that doesn't speak well of managed care if the nearby state with a lot of very similar conditions is having higher costs with managed care, and Idaho is having lower costs without managed care for that same population. So we found a really interesting case of a state that got rid of managed care. So after many years of lobbying by, frankly, folks who are very progressive, probably not the kind of people we would normally look to, the Connecticut legislature was convinced to get rid of their comprehensive Medicaid managed care organizations and instead go with just an administrative service organization model. So they have an organization that does the paperwork, but they don't make any determinations. They don't restrict care in any way. They're just sort of a pair of hands to do operational work. And Connecticut implemented this in 2012. Their per month, per member cost in 2022 was still below the level in 2012. And that was a period when we had quite a bit of inflation, especially healthcare inflation. So it's a pretty impressive result, from a cost point of view, even though I don't think that was the original intention. But from a cost point of view, I think that's a pretty dramatic result that by getting rid of managed care, they were actually able to contain their costs.
Wow, that is really substantial, especially and you don't see very many states that actually reverse a policy like that as well. So it's nice to be able to look at Connecticut as that example of a state that tried this out, decided that wasn't working for them for controlling the costs. One of the states that I was talking to another colleague about while we were really studying this managed care thing and figuring out how to cap costs in Medicaid was Rhode Island. And they did an interesting, I believe they call it it was like the global, it was some sort of the global compensation rate or something like that. I'm probably totally butchering the name of the program right now. But basically what they did was they went to the federal government and they said, hey, we want all of our Medicaid dollars delivered to us in a block grant. We don't want it to be open-ended. We only want a 2% inflation adjustment per year. And that's how we want the federal government to reimburse our cost for services. And everybody says, okay, well, what does that actually do? And what they found was this has a novel concept of putting the government on a budget. In all other states, Medicaid is just this open-ended program where you can spend until it reaches an end, and it's taking up larger percentages of state budgets. And so in Rhode Island, it forces them to go, okay, well, the federal government's only going to give us this much money, and so we have to figure out how to efficiently run our program, and figure out how to make healthcare more efficient and more effective for the people that are on it, and put some sort of cost constraint on it, like that. Do you have you looked at?
I'm not aware of that, and I did notice that Rhode Island was actually considering a bill in the last session. It didn't. I think it died, but they were considering a bill to follow the Connecticut model of getting rid of managed care.
Really?
So there's that. I think in the current context of the Biden administration, I think we'd have the same problem that we were talking about before off air with Utah, which is they went and got a waiver from CMS saying, hey, we're going to limit the growth of our Medicaid expenses to the growth of the general fund revenue. I don't think Biden administration would permit anything like that. I think they're very much into the idea that maximizing the number of people using the program and maximizing the number of services. And so anything that puts a hard cap on what Medicaid can spend, I think they would see that as being, bad for patients. We might disagree with that. I think it's an honest motivation that they have, that they just feel that the more money we spend providing health care, the better off everybody is. But I don't believe that's the case. Unfortunately, they're in power right now. They do, and so I think, if Idaho, for example, were to go for a waiver like the one that Utah got in 2011, or the one that Rhode Island might have gotten earlier, I think that they would not be successful.
I agree with that assessment as well. And I want to say that's probably one of the biggest problems with the bureaucracy and how they run these Medicaid programs. They look at these people on the system as customers instead of people that are on the program. You're supposed to help them get on their feet and then get back off the program and into the private market. And so then what ends up happening is you have the government trying to figure out more ways to increase the number of people that are on the program. And it's just unsustainable. At this point, we kind of have a pseudo expansion with the ineligibles being on the rolls through the public health emergency and maintenance of effort program. And it's just kind of snowballing, and you see this in a lot of states, right. As the program gets more and more expensive, and it's eating up larger portions of the budget as well. Exactly. I know of a few studies where it's starting to crowd out education spending, it's starting to crowd out a lot of things. In the Utah presentation today, they said that while they were trying to evaluate Medicaid spending and what to do about it, they were projecting about 50% of the Medicaid budget one day would be, or 50% of the budget would be Medicaid.
What you said a little earlier reminds me of how the sort of the progressive community reacted to redetermination. So finally, Congress, passed a bill saying, okay, we're going to consider the public health emergency over, and now we're going to wind down this what that's called state maintenance of effort requirement, so states can begin to decide who really is eligible for this program. So you hear things like, oh my God, Congress has decided to kick 15 million people off of Medicaid, creating the assumption that those 15 million people would now no longer have any access to health care. And I mean, I understand that perspective, but I think it misses a couple of points. First of all, if you go 3 years without reviewing eligibility, you don't know whether people have died, whether they've moved out of the state, whether they've gotten a very high-paying job with wonderful health benefits and so don't need Medicaid. And this is the kind of thing that is determined by systematically reviewing eligibility on an ongoing basis. But in many states, like my home state of California, they've been very reluctant to start with this redetermination process. It only kicked off in July. I believe here in Idaho, we really got started in April, and even prep work was done before that. Mm-hmm. And then it's like, well, we're not going to do a bulk redetermination. We're just going to wait for everybody's anniversary date, and we'll reinvestigate their eligibility at that time. So the whole process isn't going to finish until like a year from June. Mm-hmm. So meanwhile, California had a $31 billion budget problem when the governor's budget came out back in January. And there's this obvious way that California could have reduced its state spending by simply making sure that whoever is on Medicaid actually needs it. And they don't do that, and so other things have to be cut. So to your point about this being a thing that squeezes out other kinds of spending, that it definitely does.
Absolutely, and that was another thing too, where at the beginning of the redeterminations period, there was a report that came out from the Paragon Health Institute that actually quantified how much it would cost to delay the start of redeterminations. And for Idaho in particular, it would have cost $42 million per month that we left those ineligible people on the rolls. And that's another problem that came up in the testimony was the Center for Medicare and Medicaid Services, as of last month, announced that 9 states have decided to pause their redeterminations, and Idaho is one of them, specifically for the procedural redeterminations. And it was because the Biden administration has this extensive list of ways to reach out to people and pre-filled forms, and making sure that, like, if somebody's enrolled in a different government program, then they would automatically qualify for their Medicaid to be reinstated and things like that. And there were some issues with how Idaho did that. And so Idaho paused those procedural redeterminations until they could get that resolved. But the problem is that delayed that end point of when all of those people get removed from the rolls. What we're finding in states like Florida as well is a lot of these people knew that they were already ineligible. And why go through the process of filling out all that paperwork to check your eligibility when you already know that it's not worth the time?
I mean, I guess the good news for Idaho is that a lot of the redeterminations had already been completed when this pause happened, and I think we heard something like 100,000 people have been removed from the rolls. That was, I believe, the number that we heard earlier. We had done a Public Records Act request as of July 1st, and we had heard that we had learned from DHW that the rolls had gone down to 388,000 total, probably including CHIP from 450, CHIP, the Children's Health Insurance Program. We then later learned that Medicaid-only enrollment is now down to 361 as of July 1st, from a peak of 419. So that's 58,000 less between the peak of enrollment at the beginning of this year and July 1st. And perhaps there were some more redeterminations after that help us get close to that 100,000 figure that was floated. But a lot of people are off. So I think the good news for Idaho is that while you're not going to get down to the level that you would have gotten down to if there hadn't been that pause, that scary Paragon Health Institute number, $42 million a month, probably won't happen given the amount of progress that's been made.
Absolutely. And so you're from California, and you were saying that there's some concerns with how California is removing people from the rolls, and their budget problem. But they're also a managed care state, and they're also looking at having to figure out how to control those costs. And so what are the things that they've tried, and are they working in a state like California? What does I guess the question
Right.
is, what does Idaho have to look forward to if we continue down this road?
Well, I think, in terms of per month, per member costs, California is not extraordinary one way or the other. It's in the middle there. One thing that California does really well compared to my original home state of New York is how it deals with the nursing home population. So when I had to deal with my mom's long-term care, she was originally in New York. They put her in a nursing home, and it was going to cost like $21,000 a month. I brought her to California, and they said in California we have something called a board and care facility. So this is a home that up to 6 elderly people can live in, or even non-elderly people, just people who need help with the activities of daily living, ADLs. So that we'd be 6 residents and then 2 care providers. So it's not a skilled nursing facility, but 9 times out of 10 or 99 times out of 100, older people or people with special needs don't need a nurse. They need just to get help, getting fed, getting changed, and whatever. So compared to the $21,000 that the nursing home wanted to charge, this was $4,500 a month.
Wow.
And I think that is, an innovation that California has had for many years. I think it's worked out really well in terms of, reducing the cost of that high expense, long-term care population. So even in California, sometimes we do something right.
Amazing. Well, thank you for being on the show. Appreciate it, and safe travels back to California. And we love the work that you're doing at Cato. So thank you.
Thanks for having me, Nick.
If you enjoyed watching our conversation, please be sure to like this video and subscribe to this channel to keep Idaho Freedom content in your newsfeed. If you want to see more of what Marc is doing over there at the Cato Institute, be sure to go to cato.org or follow him at JoffeMD on Twitter. Thank you for watching, everybody, and hope to see you next time.